Oh, hi, welcome. I'm Flavio Martins, and welcome to the panel on data and artificial intelligence in healthcare. I am a doctor in computer science, and I'm head of data science here at the Value for Health Collab. So I'm going to start the panel with my intervention about what has been going on the past few years. So just a little bit about what the Collab is. So the Collab is a collaborative laboratory. This is a title that is given by the Ministry of Science and Technology. We are mostly concerned with outcomes measurement, citizen engagement, and value assessment in health. So this is a non-profit applied research organization. The mission is to implement value-based healthcare model in Portugal. Working together with industry partners, we have Nova University, which was founded in 1973. And this makes it the newest public university in the capital of Portugal, Lisbon. We're working with Saúde. CUF Health, I guess, is one of the major healthcare providers in Portugal. Working with Fraunhofer Portugal, which is Fraunhofer is a German research organization with several institutes focused on different fields of applied science. In this case, in Portugal, assistive technology for our case. And Vodafone, which of course you might recognize, they operate in multiple different countries, mobile networks, 4G, 5G, etc. Okay, so with these partners in mind, I'm going to show you some of the work we've done in the last 2 years. So what we've been doing is working together with local hospitals from the area. So this one is Hospital Garcia de Horta, which is right across from the river Tagus here. We're working with our group of resolution of high users. So we joined the efforts of this special task force at Hospital Garcia de Horta. And we are using their electronic health records from their own hospital and from the emergency department to analyze the high users and also the frequent users of the emergency department. So this is a problem that is global. It's not just from this hospital, of course. There's excessive use of emergency department, and it's a source of a lot of waste in health systems. Our work here has been in quantifying the impact of their intervention. So their intervention includes personalized integration plans, and we're trying to come up with value-based metrics that take into account costs as well as effectiveness that can be used in a tailor-made health information system that these teams are trying to put in place to make their work more effective. Continuing in the line of the types of collaborations that we have with local hospitals, we run a pilot in a public hospital in the center of Lisbon, in the Department of Cardiothoracic Surgery, and we're using IoT devices to monitor the post-operative moment, and what we're doing next is trying to scale up this pilot study, which had 35 patients till now, and we're trying to scale it up to 300 patients. Okay, so this is a funded project that we're starting now after this initial pilot, and it's in collaboration with Fraunhofer, Nova Medical School, Vodafone, and of course the Santa Marta Hospital, which has hosted our first pilot. We also have other projects in other national projects or grants. Where we have this Frail Care AI project, which deals with electronic health records for the senior population. We're trying to find intelligent pathways for the elderly population and try to assess the impact of the screening that is done by the National Center of Contact. So we actually have this system in Portugal, where this center of the public health system will call out to people instead of receiving calls. They do this outgoing work of screening people. So our role here is doing, of course, all the data warehousing, automating the selection of people to call, those that have higher risk of frailty. We're building this intelligent decision support system that will help the people in the field, in the help desk center, select the people that need the most to be contacted. So one of the things that we're also doing, we're looking into the role of science communication, in this case health communication, with regards to the pandemic. So one thing we've done is we've tried to kind of do our part in fighting health misinformation. We've participated in the track health misinformation track, trying to improve the responses to queries that are health related. We've collected information about COVID-19 from social media and online newspapers, because we found through a survey that people were getting most of the information from online newspapers when the lockdown started. And we're trying to make this health-related news cycle more transparent. Just as an example, there's a search here about ibuprofen, and you can see that there are two media publishers here. One of them is really sure that ibuprofen at the top, there's no evidence to show that it does harm or not. The second media company actually goes back and forth throughout 6 days. Okay, so you see that there's a fact check, then they take out the fact check because they're not sure anymore. So we're doing these kinds of things. So the team doing this is Pedro Dias. He's a biomedical engineer. He's doing mostly software development. He did most of the work in the pilot for Santa Marta, so the cardiothoracic monitoring. We have Joana Gonçalves, a master in big data. He did most of the work on the high users analysis. And we have Miguel Cardoso, which has been working with us also in track precision medicine and in frail care. So I will end my intervention here, but if the people that are looking into the stream have some kind of data that they want to have analyzed and they don't have the know-how to, just shoot us an email. Data is usually what we don't have, and if you do, we'll do the rest of the job. So right, just next, what I'm going to do is present the panel. So I tried to gather experts in the field from different walks, I guess, to talk about the challenges for artificial intelligence research in healthcare. They share, of course, similar interests, but they work in very different contexts, institutions, and even jurisdictions. They're from different countries even. So the discussion should revolve around the challenges and opportunities, and how each panelist contributes to the advancement of this field, or or fostering innovation in this field. Okay, so I'm going to introduce them, but they'll have, of course, the opportunity to introduce themselves in the first round. There's Cátia Sousa Pinto, a medical doctor. She's a specialist in public health, working in the advanced analytics and intelligence unit of this public institution, which is called Shared Services of the Ministry of Health, which, among other responsibilities, provides the health information systems to our public care institutions. We have Henning Müller, which received his PhD in computer vision at the University of Geneva, where he's also now a professor in the medical faculty. He's a professor at AGSSO Valais in Sierre and the head of the eHealth unit. Also invited William Hersh, also a medical doctor. He is a professor and chair of the Department of Medical Informatics and Clinical Epidemiology in the School of Medicine at Oregon Health and Science University. Those that have worked with data know that they produce some data sets. He's from Oregon, USA. Dr. Hersh is, of course, a leader and innovator in biomedical informatics and research in this area. Also invited Joana Gonçalves de Sá. She's an invited associate professor at the Instituto Superior Técnico, a principal investigator at the Laboratory for Instrumentation and Experimental Physics. Her work takes a systems level and data science approach to study complex problems at the interface between public health, computation, and social sciences. Finally, last but not least, Yubin Kim. She received her PhD from Carnegie Mellon University. She leads the machine learning team at the University of Pittsburgh Medical Center Enterprises. This is the innovation arm of UPMC, which you might recognize as one of the largest integrated health systems in the US. So without further ado, each panelist now will have 2-3 minutes to present himself or herself and briefly refer to his interests in the session theme, right? So I'm going to start by Cátia Pinto from SPMS.
Hi, Flavio. Thank you so much for inviting SPMS to this session. I think you said already most of what I would say about myself. Just to mention that SPMS is the National eHealth Competent Agency. So we are responsible for development and the operation of the national health information systems. And I'm a medical doctor and a public health specialist, and I work at the Advanced Analytics and Intelligence Unit. So this is a special unit within SPMS. We deal mostly with secondary use of data, and we deal with secondary use of data in the governance side and also in the operational side. We are responsible for development of IT solutions that reuse data generated by the healthcare system in Portugal, either from the National Health Service, but also other data that it's collected by us in order to provide database solutions to the National Health Service. And this is either in clinical decision support, public health surveillance, and health administration. So I'm very much excited in participating in this session and trying to push forward the use of data science and AI in the healthcare sector, even at the national and the cross-border level. Thank you very much.
Thank you, Cátia. So I will move on to Henning Müller. If you could talk a little bit about your role in this field.
Sure. So I'm mainly working on medical image analysis in connection with other clinical data and machine learning on such medical imaging data. The objective is to build decision support, like clinical decision support systems that include visual data. And I mean, in that respect, the topic of the panelists is totally relevant in all aspects because we use a lot of data. We need to have access to data. We need to be able to know how we can use it, how we can share it, and all these kind of aspects. And particularly open science is a domain that has been very important for me. I mean, we've been organizing scientific challenges, and in that respect, it's very relevant. And I think also in general, data analysis, clinical decision support has a lot of potential and can help in many domains.
Thank you, Henning. So I heard you talking about organizing this contests or challenges in this area. So I have to pass the word to Bill, I guess, which is also known for doing this kind of work. Bill, go ahead.
Well, thank you for the invitation. I would much rather be in Portugal, and during the pandemic, I've gotten to visit many places around the world virtually from here in my basement, although I'd rather be there in person. But as Flavio mentions, my longstanding interest has been in information retrieval or search. In the early days that my work focused on retrieval of literature, and then in the last decade and a half, moved towards electronic health record data, and actually including images. And Henning and I, a number of years ago, collaborated on some early image retrieval evaluation. So my focus is on evaluation, both of the systems that I might be involved with, and also how we can compare across systems. So I have been involved in a number of challenge evaluations through the text retrieval conference in the US. But really in the last few years have focused on retrieval of electronic health record data for tasks such as patient cohort retrieval. And that's work actually started in Trek. We subsequently received some grant funding from the US National Library of Medicine and continue to do that work to look at the best ways for many different types of queries on how to identify patient cohorts. I also have larger interests, maybe there will be more time to talk about it, but just to mention briefly in the quality of data, what we can do with electronic health record data, and then also how we translate these research systems into the real world and actually evaluate them there, which I've also done with search systems and real users. So I'll stop at that point.
Thank you, Bill. So there's going to be more time actually in the next round to talk about the other issues, of course. Joana Gonçalves de Sá, if you would please.
Hi, hello.
Hi.
Good afternoon, everyone, and again, thank you for the invitation. So, for also focusing on this area, I've been leading a very multidisciplinary team to look at how we can improve decision making and understand human behavior from the health perspective. So, how the behavior impacts health and how different decisions, individual decisions, impact the public health issues. And we've been working with a lot of microdata also from health records, in part for some in collaboration with Cátia with health. And most of this has been now funded by the European Research Council. And we do a lot of data analysis, machine learning, all of these things. And we have a big focus on privacy and ethics of using health data. So we've also been trying to work on new computational approaches, including distributed computation or encrypted machine learning, to provide services that are particularly privacy protecting. And this is something that I care a lot about, so I decided to mention it about the transparency.
That's why I invited you all. So everyone has their favorite theme. So now I think it's Yubin, right? Yubin, if you could talk about your experience, which I think is a little bit different. It's more industry. Yeah.
Yes. Thank you so much for the invite. This is an august panel, so I'm very excited to be a part of it. So I am more in the industry side of things. So I'm in an interesting place in UPMC, which is this big integrated delivery health system in the United States, mainly headquartered in Western Pennsylvania, although we have hospitals across the world. And Enterprises is actually this arm where it is fosters innovation within UPMC. We are kind of the entry point for a lot of new healthcare tech startups to work with UPMC and developing also machine learning in-house as well. So I lead a small team of machine learning engineers. We're a bit of jack of all trades, and the problems that we worked on touch on a lot of different areas. We've done computer vision stuff with the ophthalmology department, and analyzing retinal scans. We've worked with operations, so places like revenue cycle and claims processing within the healthcare system. We've worked directly, especially during COVID times, helping stratify patients based on risk factors for COVID to try to help them. Done the usual clinical decision support stuff like predicting colorectal cancer, predicting bladder cancer. So my team's work spans a lot of different areas, and we work very closely with stakeholders directly, both in the insurance and the provider side, to find problems that are high impact and need solving. And we also work directly in co-development with startup companies as well as they come through the UPMC system. And we have this interesting 3C model that we call for working with startup companies, either co-development, customer, or investment in capital. So how enterprises invest in healthcare tech startups is by bringing them in as so that UPMC can be a customer of their platform. And so not only are they benefiting from the capital investment that we make, they also benefit from having access to the huge patient population of UPMC and developing their healthcare tech on our platform. So happy to talk more about this. I think we're in a really, really interesting spot, bringing healthcare research and healthcare tech into the real world and into patients' and doctors' hands. So I'll stop there.
Great, Yubin. It's really nice to hear about that side of life, the industry actually driven research focus, and that leads us to the next round. So of course now you know a little bit more about our panelists. It wouldn't be a panel on data if we didn't talk about it, how we access it. If we already have the data, if we need to annotate it, what kind of form does the data you use take, and where do you extract it from? So in a way, we want you also to talk about how you are using this data to transform healthcare, and what challenges you face with working with this data. So what are the primary sources of data? Do you have exclusive access to some interesting data that you wish you could publish? And of course, for Yubin, do you deploy systems in production, and maybe there are human factors there, and any resistance or any stories you can tell? So let's do the same order. Maybe Cátia could talk about how FPMS is fostering innovation, being kind of the data holders.
Yes, Flavio, this is I think these are very exciting times for science and for research. Never before in the last years we heard so much talk in social media, out in the community, about science and the value of research. So we are really at an inflection point in the digital transformation of healthcare, where not only data is being recognized as a masterpiece of healthcare service themselves, but also there is great awareness among the general population, great political awareness around data. As a governmental agency has a very important, in my view, role to play in the use and the reuse of data to improve health at the national level. So we have been engaged with the development of good and strong data governance policies in order to make sure we can liberate data and give access to data for research in a responsible manner. We are deeply committed in, first of all, ensuring population's trust around the secondary use of data. And when we talk about public health data that comes out from hospitals and primary care centers all across Portugal, we need to make sure that our patients really trust us in the handling of data, and that they trust that when we share their data for research and for innovation, AI development, we are doing it in a responsible manner. So in my perspective, what we have come very far in Europe with the data protection regulation. And the RGPD is today recognized worldwide as a cornerstone of data reuse and as an example that is being followed by other countries in the world. So what we need to do now is to regulate data sharing. And the latest Data Governance Act, the latest proposal for the Data Governance Act and the Artificial Intelligence Act that has been published by the EU Commission really sheds light on what we need to do either at the European level and at the national level. And that is to regulate how data is accessed, what we mean by anonymization, and why patients can trust us that their data is being used for the public good. Of course, this also means dealing with other challenges that have been long facing research that uses health-generated data. And I'm talking about, for example, data quality. Data quality is actually one of the pillars of data governance itself. We need to make sure that among this data governance framework, we have data quality, we have a specific data quality framework to ensure that we can use the data in the right way. We need scientific qualification for the data that is generated by electronic medical records, for example, that it's one of the focus of our session today. As you know, electronic medical records worldwide have been have their birth with very different legal administrative pressures, and very rarely there were even clinical concerns or data reuse concerns that were in the basis of the generation of electronic medical records. So today we face and deal with several problems that come from this piecemeal development and sometimes siloed development of electronic medical records, even in countries like Portugal that have national healthcare services. So among data governance, data quality is for me one of the culprits that we need to address in this new era that I think Europe has been developing with this proposal for the Data Governance Act. And from our perspective as a governmental agency, our role is really to make sure that we use data in the right way, and we have the patients with us when we need to reuse data, either for public health surveillance, for innovation, or for AI development and deployment. I don't know if I still have some time, or if we
Cátia,
can.
let me pass the word to Joana, which actually is pretty much concerned with these kinds of data sharing regulation and privacy concerns, and maybe she can add to what you just said. Joana, if you could comment on my questions as well as connecting with what Cátia just said.
Yes, I completely agree with Cátia. Of course, there are all these different levels. Data quality is one of them. The trust is a fundamental one, of course, from the patient perspective. But I think we run the risk of using bureaucratic hurdles sometimes to limit. Okay, so let me say this in a different way. Under the concern of patient privacy or data owner privacy, we run the risk of creating just adding bureaucratic hurdles that do not help the patient, or do not help the user, or do not help the scientist, and just protect the data owners, just protect the data handlers, the institutions. So for the institutions to legally protect themselves against lawsuits, or they create barriers to data access that are not necessarily helpful and that do not necessarily improve privacy in any way. So I think there are many different, and this is a risk. This is a serious risk, and we've been talking about data leakage and data problems in Portugal and elsewhere, especially from the state. And we have to. There are important decisions to make, because if the institutions are permanently under fire for any sort of issue with the data, not only we don't build trust, but we are just promoting a kind of policing that is not helpful. On the other hand, if we do not take the important steps to protect for trust and to protect the privacy, we will never be able to use data as it should be. And I think in some ways, this problem has been solved by others before us, not necessarily with access to medical data records, but with access to labs, for instance. So we have different security levels when we're talking about biological labs. We have the BL1, where people are working with yeast or flies, and you could basically eat inside because nothing of it is dangerous. But then you have BL4s that you go inside looking like an astronaut, and you need a lot of clearances in order to get access to. And if we could think about getting this sort of clearances for researchers, for data scientists, and then the moment that you get cleared, you have access to a certain type of data, you could ease the access of scientists to data, researchers and medical doctors and everyone who needs access to them, without having to go through the bureaucratic hurdles and every time that you need access. Now, we are now here just talking about the electronic medical records, which are fundamental, but then we have all of the non-medical records, or that are considered non-medical, but that sometimes offer the same type of information. For instance, if we can anticipate, or if we can have good predictors of anxiety or depression just by behavior on social media, this is not a clinical record. This is not necessarily considered personal sensitive health information, but just the way people behave online offers a lot of very sensitive private information that we are not taking into account, and anyone with access to computers or with access to all of these things with these techniques can actually identify features of anxiety or depression, which are very sensitive information. So I think that these discussions are very important, and we really need to strike a balance between putting the emphasis on protecting the data and not necessarily the institutions.
Thank you, Joana. So I'm going to talk with Henning, which I guess is not covered by the RGPD. I'm not sure. I think it's the other way around.
Well, Switzerland usually adapts their laws very quickly towards the European law. So they're currently having in the parliament a document that actually resembles very much the RGPD. So usually the Swiss regulations are very, very similar to the European ones, and they're adapting to it. It's not necessarily exactly the same word by word, but as the RGPD also concerns hospitals treating European citizens, I mean, Switzerland is very concerned because Switzerland's surrounded by EU. So I think everybody who has been looking has been following it very, very closely in that respect. And I mean, I totally agree with what was said before. I think it's important to check, like, to strike a balance between the reuse of data, research data reuse in an anonymized form, but also the protection of privacy. I mean, I think these are both very important things. Also, the AI regulation. I think it's important to think. I mean, what is a human, sensible use of the data? So we're not just doing something because it's possible, but we're thinking about what is the outcome of it. And we've had a few EU-funded projects actually on safe use of data. We were actually not moving medical data anymore, but we kept them in the institutions, and we actually moved the code. So the researchers developed code in virtual machines or Docker containers, moved it into the institutions, would then get evaluated outcomes of that. And I think that's also a way to think about it. Having a distributed storage, distributed machine learning is, I think, a very important domain that that we need to look into, and that has a lot of potential. And I think there are quite a few ways that can actually assure privacy and that allow like the data sources are not matched, because usually when you have an anonymized source, it's pretty difficult to identify patients. But if you have several sources and you combine them, that's when re-identify, I mean, voter records or these kind of things, that's when re-identification might be possible. And there was a talk about data quality. I mean, as we're really deploying like machine learning on medical data to do decision support, data quality plays an important role. But there's often a mismatch between what is in the electronic patient record and what is used for research. Because for research, you use very clean data, manually selected. It's very different from clinical data. I mean, if you look at imaging, all the protocols can be different. I mean, everybody has their own imaging protocol. So then the question is, how can you actually compare these data sets? And when you look at radiomic studies, I mean, these are often done on cohorts, but everything is standardized. And that's just not the way the clinical data work. And I think if we want to bring clinical decision, AI-based decision support into the clinic, we need to take that into account. The algorithms actually need to check what are the changes that happen when you use a different reconstruction kernel on a CT image, for example. And you can have low pass, high pass effects. And then if you use radiomics features that are often used in oncology, for example, to make treatment decisions, they're completely different. I mean, you don't want to make a decision because somebody uses a Siemens and somebody else a Philips scanner, for example. And these are some of the projects that we're currently working on to actually see like what are the similarities and differences and what can we actually compare once we start extracting features from these images, and how can we also use deep learning to actually make the extracted features invariant from these kind of influences of the reconstruction algorithms or these kind of things. I think that's something that really needs to be taken into account also when we talk about data. It's not only the quality, that what we're using for building systems actually needs to correspond to what is inside a clinical record. And I think these are a couple. I mean, I could go on and on these kind of points,
one of the
but I think
questions,
these are really important things.
Sorry for interrupting you. So one of the really interesting questions that I think the answer will be interesting is, of course, you are associated with a university hospital there, so you mostly probably have data from that hospital in most of. How does it work? So
actually,
the heterogeneity of data probably doesn't happen so much, or does it happen in a single institution?
There's a variety. I mean, we work very closely, mainly with 3 hospitals in Switzerland. I mean, it's mainly Lausanne, Geneva, a little bit in Bern. But these are the closest university hospitals that we work with, and they have a very large research activity. So quite often we actually have a clear clinical setting that we use, and then we're trying to build a system based on the data that we're acquiring. But quite often what we use as well to also increase diversity of the data we have, we use like public repositories with like TCGA, the Cancer Genome Atlas, or TCIA, Cancer Imaging Archive. They're fairly big repositories. It's not necessarily the same images that we have, but we can always check if we're overfitting on the data that we have, or if we can build something that would actually generalize to other sources as well. And another big problem that I don't have a solution for is that actually imaging equipment changes pretty quickly. So a CT scanner is replaced every 5 years. New scanners produce different images, different resolutions, different types of protocols. And then we would need to retrain actually the algorithms. We really want to make sure that they work. So either we need to have something that really generalizes well, but maybe on a lower level. But if we want to have very specific applications, we would need to retrain again. So once you start the cohort, actually, and once you have the data, you would actually need to reacquire new data. So, I mean, these are some of the problems that I think we need to look into and tackle as well, inside the institution, but also across the institution.
Thank you, Henning. So I would like to hear Bill also about what we've been talking about, and also about the patient cohort work that he's been developing. Of course, he's promoting also the track precision medicine tracks, or clinical decision precision. I'm not sure how it's going to be called this year. Maybe you could talk about that.
Yeah, well, if you don't mind, I'd actually like to just go a little bit more, elaborate on this theme of the data and the electronic health record. You know, because I work with another type of data, namely text. And it's interesting to hear Henning, because I always think of images as a very consistent and clean form of data, but obviously they're not. But text is even worse. But on the other hand, the text in the medical record it gets into detail that the diagnosis codes, the images, the lab results and so forth don't really get into. It captures what the patient's experiencing, what the clinician is thinking and so forth. But that textual information, I used to work a lot in the early days with medical literature, and that text is relatively clean. It's you may violate copyright law if you release it, but the information in text in the medical record is the most personal of personal health information. Yet that's where the insights are. And there's no perfect solutions to working with it. We do some work behind our firewall, which is great for us, but we can't share our data with anyone else to see if they can get better results. We can let algorithms in to work on the data, but that's unsatisfying for the people who develop those algorithms, because they can't really analyze where their systems did well, where they did poorly, and so forth. So, some people are looking at synthetic data. Maybe that's the solution, but it's not clear. Other people are trying to de-identify this data, which for some purposes works. But again, most institutions will not let you release their de-identified textual information because of the concern of the lawsuits and so forth. So unfortunately, there's no perfect solution. But in any case, the Trek Precision Medicine track actually gets back to literature, even though it's based on de-identified patient cases. That's kind of the information that then lets us go into actually the medical literature. And actually we're evolving this year to focus on clinical trials that are cataloged in clinicaltrials.gov, which is another source of non-patient information, which is much easier to work with. The National Library of Medicine will let us basically download the entire clinicaltrials.gov database and use it for our research. But with patient data, that's where the real challenges are. And we probably need to work out solutions to let people who are trusted third parties, honest brokers, mediate access to data, having patients understand that their data can be used this way, and making sure it's used in the proper manner. Another concern is bias in data's, racial bias, other kinds of bias that lead the algorithms to reach conclusions that are really not appropriate. These are all issues we need to address. This is probably a research area in and of itself, to how to use this data most effectively, because I can't see benefit on the other side of leading to improvements in healthcare, better care for patients, better ways to allocate our limited healthcare resources, and so forth.
So it's a question of a balancing act, right? Really. Mm-hmm. So maybe Yubin could talk about this subject as well, and then we'll have a round of just you talking about what changed with the pandemic, and if you have high hopes for any new technology field or development in this area. So let's hear Yubin first.
Yeah. So. Oh boy, where do I start? So I have a lot of things I could talk about, but I'm going to keep it to a couple of points. So one, I'm going to talk a little bit about what healthcare data looks within the walls of healthcare systems. I think that'll be interesting. I think I will talk a little bit about the data governance that we at UPMC have around protecting patient information, and a little bit of the challenges that I see from within the great walls of healthcare systems having access to the data, but still we have problems. So to give you an idea, in the US, right, there has been a government legislation passed by when President Obama was around. It's called the 21st Century Cures Act, and a part of this act basically told healthcare systems that you need to make your patient data interoperable if you are ensuring any US government-based insurance programs, so this is like Medicare, Medicaid, you need to make that patient data available by PHI, by API access. So there is a big effort in the US pushing towards interoperability, but it's a long haul. So within UPMC itself, we have something like 45 plus hospitals, lots of patients. The best organized source of information we have is clinical documentation. We invested millions of dollars building out this clinical document repository that contains 8 million patient documents, 8 million patients, 300 million plus documents, and it's updated live. It is on the cloud, in AWS, API accessible, everything. It's fantastic. Now, unfortunately, other sources of clinical data, not so well organized, right? So all the information that's locked away, so that's the structured data, discrete data, stuff in Cerner and Epic, and the 40 other different EMR systems that our hospitals uses. These are all locked away in those databases. We have a team that has some copies of these tables and views that are built on top of these tables, but this is an on-prem Oracle database. Right, not easy to build stuff on top of. In the health plan side, so this is like billing and claims data, they are actually moving towards the cloud right now using Snowflake. So we are moving towards the cloud and trying to get the data in place so that we can innovate within the healthcare system. We can build production systems on top of it, but it's still a long journey still.
It's mostly on premises now, right?
So the clinical document repository is AWS cloud. The clinical structured data stuff on-prem, the health insurance side data, claims data, and billing data moving towards the cloud is kind of where we are. So mixed bag. And from our connections with in the VC network, people who talk to a lot of different healthcare systems, we're ahead of the pack. Let's put it that way, right? So just from the perspective of getting data technically out of healthcare systems alone is going to be a challenge.
We're actually reaching the end of the session, so I'm gonna have to stop you there. I'm really sorry, but let's try to do the last round in a flash way, I guess, and each of you can have 1 minute to kind of express what new interesting research problems are worth pursuing at the moment, and maybe you can talk about if this opinion has changed due to the pandemic, and if you have done anything differently when the pandemic struck. Okay, so let's do it in order. So maybe Cátia.
Okay, Flavio. So I'll make it very quick. I don't think the pandemic changed the fundament. It only reinforced the fundamental need to have universal health coverage and quality of care, and to have resilient healthcare systems and interconnected intersectoral collaboration of healthcare with other sectors. I think a research focus should be on innovation that can make us achieve to have a renewed approach to universal health coverage and make us achieve higher levels of resilience and prepare for the next pandemic.
Thank you. So, Henning?
Well, I totally agree with the fact that I think the pandemic didn't fundamentally change things, but it accelerated quite a few processes also towards digitization, distance work, telemedicine. I mean, these kind of things, really having all of the data available at different places. I mean, that I think is something that became really important. In terms of our research and important directions to look into, for me, something that I'm currently looking into to build real systems, I think we need to be able to explain AI systems, outcomes, why a decision was taken, because it's still clinicians using the system, but also it's important to find biases. If you have biases in your data, if you have problems, like maybe the decisions taken because of a wrong thing, if you have tools for interpretability and explainability, I think it's very important, particularly now that deep learning took over absolutely everything. It's really difficult to actually understand sometimes why a decision was taken. I mean, you can do heat maps, but that only tells a very small part of the story. And I mean, sometimes it's just with the heat map, it's just impossible to actually understand what's happening inside a deep neural network.
I agree. Bill?
Yeah, well, I completely agree with the previous two speakers. The pandemic, certainly in the US, has exposed the problems with our information system. Actually, it's also exposed a lot of problems with our healthcare system in the US. But not having good data, not having interoperable data has been a problem. But going forward for AI in medicine, I believe the absolute thing is to really figure out how to translate it from what one may call the basic science, just like drugs start out in animal experiments and tissue cultures, and then they're moved to humans and then into the healthcare system. I think that that AI approaches need the same sort of thing. In the quote unquote lab, we can show that deep learning algorithm reads x-rays as effectively as clinicians. But how do we actually implement that in the real world? Actually, some of the imaging system challenges that Henning talked about, and how does that improve healthcare? How does that improve patient outcomes? I think that's where the real important research is to be done. How we make AI actually benefit people and healthcare systems.
Thank you, Bill. Now it's time for Joana Gonçalves.
Yes, agreeing with everyone. I also think that the pandemic really revealed that we need to improve our information systems, and that and not only in these terms of interoperability, which are fundamental, but across nations. So the integrating information from different sources nationally and internationally, I think we all felt that this was very slow, even at, for instance, ECDC or CDC level, because people were collecting data in completely different ways, and we were afraid of unstructured data. And because we did not have structured databases to put it, to include all of this data, I think we lost a lot. We lost a lot of information just because we didn't want to keep it unstructured, but we didn't have the structure to keep it. So this idea of thinking really top down about how we should collect the data, what type of data, how we should put it together, and how we should share it internationally. I think this is something that I really hope that in the next few years we're going to work. From my research, I'm very interested, like I said in the beginning, in how can we put behavior into the health, and how we can think about our actions and how they are interfering at the individual and at the public health level. And these are typically not collected types of medical information or clinical information that I think are very relevant and really can move us forward in thinking about predictive medicine and so on.
Okay, so last but not least, Yubin again.
Right. So in terms of how COVID affected the work at UPMC, a lot of emphasis towards telemedicine for sure, but also in terms of making the people who are working in healthcare more efficient. The healthcare system was really overloaded. So we had work in terms of prioritizing patients, connecting ICU doctors to more locations remotely, and improving operations and back office stuff as well. I think that's an area that's a little less sexy, a lot less people work on it, but there are actually very interesting problems in billing and revenue cycle, coding, abstraction that could use a lot of machine learning and AI help. So looking forward to more there. In terms of areas, and this is my wish list, right? I wish you would all work on this for me. That would be fantastic. In federated learning, privacy preserving ML, how are you going to do that? I am also keeping an eye out for a winner to emerge in terms of healthcare data warehousing. No clear solution, no clear winner right now. And I think once something emerges like that, it will be much easier to share interoperable data. And so those are some of the things that are top of mind for me right now.
Thank you, Yubin. I agree with everything. Maybe not the billing part, but mostly what you said. So this reaches the conclusion of this panel. I want to thank you so much for your time, each and every one of you. This has been a real pleasure. I'm just going to kind of sign off and pass on, move on to Ana Rita Lundral, our executive CEO, which will do some closing statements for the day. This is the last panel. Please, Ana Rita.
Thank you. Thank you. And thank you all in this session.